Hello, everyone. My name is Gabrielle Altit. I'm a neonatologist at the Montreal Children's Hospital. I'm also the principal investigator of the NeoCardioLab website. And today I will be presenting one of my talks I will be giving at the UCSF Pulmonary Hypertension Conference. But before starting, I just want to mention that the NeoCardioLab content received an unrestricted educational grant from Mallinckrodt Pharmaceutical, for which we're very happy in order to be able to continue the work we're doing for gen providing the content on this platform. So I will start with my presentation. Um, I will be giving a talk at the 18th International Conference on Neonatal and Childhood Pulmonary Vascular Disease on March 28, 2025. And I would like to really thank the organizer. It's quite an honor to be able to present at this conference, which is really a fantastic conference in San Francisco, organized by some of the leaders in the field in pulmonary hypertension, Dr. Jeffrey Fineman, Dr. Roberta Keller, Dr. Bernard Thébaud, and many others among the organization committee. So I'm very grateful to be part of this fantastic conference where the leaders and other members of the pulmonary hypertension community are joining together in order to exchange knowledge and discussions. And so today I'll be talking about a perspective on neonatology-led and multidisciplinary teams in the management of pulmonary hypertension in the NICU. I have no disclosure relative to this presentation. And at the end of this presentation, my hope is that the participants will be able to outline the pathophysiology of pulmonary hypertension BPD, talk a bit about a screening strategy driven by neonatology cardiology collaboration, and discuss the management strategies in BPD-PH, which must be multidisciplinary in these patients, knowing that they have multiple front to touch. So I'll start with the story of one of my patient partners. This is Miss Sima, who was born at 24 weeks and was really on minimal setting of respiratory support at 36 weeks corrected age. Was on CPAP of 5 with 23% oxygen, and we were involved to do a targeted neonatal echo screening for pulmonary hypertension. And at the time, we found what we quantified as mild pulmonary hypertension with an RV-RA estimate of 40 to 45 millimeters of mercury, which is about half systemic, and a normal right ventricular function with no signs of RV dilatation. And so this patient was discharged actually in room air and fully fed and was sent to cardiology in order to follow these findings, and came back at 9 months of age in a situation of suprasystemic pulmonary hypertension. And at the time, the patient was actually not obviously symptomatic, but on echo had a very dilated right ventricle, a right ventricle that was struggling, pancaking the LV, and PA pressures read at 110 millimeters of mercury of right ventricular to right atrial gradient. And so, the same day he was admitted to the PICU and went to the cath lab the next day, which was a complex and challenging evaluation, and was found to have suprasystemic PVR with a pre-capillary phenotype with positive vasoreactivity. He was intubated, placed on inhaled nitric oxide, inotropes and pressors, and eventually he was discharged a few weeks later, still in room air after involvement of our own multi-D team. I was involved with respiratory medicine and cardiology, ENT, OT, PT, nutrition, and many of these other various professionals that are involved in the care of these complex patients. And so he was sent home with tritherapy, including treprostinil sub-Q, because he had positive echo response to this management. But when I was asked to talk about pulmonary hypertension, I always go back to the basic, and we know that pulmonary hypertension can represent a spectrum of disease. We know it's often a symptom of a process. And in the NICU, when I see patients for which I'm being requested to evaluate pulmonary hypertension, always keep in mind that this is a very dynamic thing. And, in the acute setting, it's one thing, and versus in the chronic setting, it's another thing. We know that pH represents a high pulmonary artery pressure in the pulmonary artery. And at times, most of the time in the NICU, it's because there's a high resistance state because we know that a pressure is often resistance times flow. And so, with high resistance, you may rise your blood pressure in the pulmonary artery, but sometimes if the RV is failing, your pressure might actually not be that high because the RV is not able to generate flow facing this very high afterload from the high pulmonary vascular resistances. And so today I really decided to concentrate on the prematurity lung disease state, but we see many types of PH in the NICU. We see babies with hypoplastic lungs and hypoplastic arteries, genetic conditions. As you know, there are congenital conditions of the heart, like congenital heart defects like truncus arteriosus or, large ductus or AP window that will cause pressure and flow transmission. There are situations of venous congestion with LV disease, mitral valve disease, or pulmonary vein disease. You can have obstructive types of disease and some of these very multifactorial conditions like BPD and CDH, for which we're often involved in a multidisciplinary fashion. And really, the endpoint of these processes is that the afterload increases and the right ventricle eventually struggles, and eventually you drop your LV preload, especially if you have no interatrial shunt to offload the right ventricle at the atrial level. And because the preload falls, you get decreased cardiac output and you go into cardiac arrest. And so, really, our role as a community is to define what's the cause in order to tailor the therapy. And so, the current definition that we use as standards for detecting who are these patients with high RV afterload are the use of mean pulmonary arterial pressure above 20 or equal to 20. But this value is really something that we can use after 3 months of age, which, it's probably something that is valid for our premature babies once they reach 36 weeks, but we don't have clear-cut criteria specifically looking at that population. So we tend to use these numbers. But a mean pulmonary arterial pressure has to be measured by cath and only can be estimated by echo if we have a pulmonary insufficiency jet in diastole. We suspect pulmonary hypertension on echo when we have reads of high systolic pulmonary arterial pressure, at least estimates. And again, this number is controversial. I think depending on where you go, you may have different numbers or different velocities. We locally decided to use the cutoff of 40 millimeters of mercury based out of the Denver literature. But I know that some will use values closer to the 33, 35 trademarks of systolic pulmonary arterial pressure. And this is only valid after 3 months because we know that the pulmonary vasculature is extremely dynamic in the first 3 months with significant drop in PVR, but this process may be altered by various factors like stress or prematurity. And so here I gave an example of a patient with suprasystemic pulmonary hypertension from a pre-capillary PH phenotype. And when we look at these patients, we actually look at all of the different components. Could this be hypoxia? Could it be, altitude? Could it be sepsis or infection or acute PH with high PVR? Or is it a question of a component of a disease like BPD or CDH? There are patients also who will present with left-sided phenotypes with what we call a post-capillary venous hypertension. And after 3 months, we have criteria to establish that. So you may wonder why Massimo or why my preterm, patient may be at risk of BPD, of pulmonary hypertension. Well, we know that BPD on its own is a subcategory of the classification of pulmonary vascular disease, and that's because their lungs are very immature and exposed to many types of injury, inflammation, oxygen, barotrauma, immature repair mechanisms, fibrosis, disturbed growth, steroids exposure. But there's probably an element of fetal predisposition, such as chorio or preeclampsia or placental insufficiency, that will change the vasculature. And we probably know that there's a component of genetic susceptibility. And so these patients who have very, very immature lung and severe inflammation from the get-go are at risk of developing lung injury, but specifically pulmonary vascular injury, where you get this heterogeneous pattern of vascular and lung injury. And so that's where it becomes more complex because you have areas of the lungs that may be pristine and areas of the lungs that may have arterial disease and areas of the lungs that may have venous disease and some areas that have both, including lymphatic issues. And knowing that, you can figure that the whole like situation is not necessarily the same everywhere. It's affected by VQ mismatch from the lung disease and airway disease. They may have CO2 retention. And on top of it, these vessels growing are often growing abnormally with increased vascular tone and with a decreased surface area. And so one thing that is good for our babies is that these lungs, as they grow, are quite resilient. And typically, as the lungs are getting better, the vessels are getting better. And so one of the key messages today is as you protect these lungs and as you help these lungs grow, that's where the treatment of this pulmonary hypertension will be key, is to prevent further injury and maximize the potential for lung development. And so we do know that our premature infants are affected by this trifecta that goes beyond even the lung because the inflammation kind of is multisystemic. We know they have moderate to severe parenchymal lung disease, which is on its own heterogeneous. Same thing for the large airway disease and eventually the small airway disease. And then you have the whole vasculature that becomes part of the issue, where you have both the right ventricle and the left ventricle that can be affected by prematurity and inflammation, but also the arteries, the veins, the lymphatics, and sometimes some of the flow issues coming from shunts. So why do we care? Well, we care because pulmonary hypertension has been associated with increased mortality in this population, and we know that it's the most vulnerable ones that are at risk of that. So extreme premature infants, very growth restricted babies, those who are born with smaller lungs, or those who are born and exposed to severe inflammatory conditions. So it is complex. I think I just outlined that there are component of VQ mismatch, airway disease, arterial venous disease, and decreased vascular surface area. And it's for this reason, and because there is a multi-systemic involvement, that you need to have a multidisciplinary team in order to be able to care for these patients appropriately and follow them appropriately, as well as train the parents to recognize the importance of this condition. So in pulmonary hypertension, especially in BPD, one of our role, at least in my unit for TnECHO, is to assess cardiac function and follow it depending on the management and evolution. We've done some studies. That's one of them that we had done when I was back at Stanford, where we had already seen that the outcome of patients in terms of mortality was associated with the RV function at the initial diagnosis of pulmonary hypertension, as well as the degree of pulmonary hypertension severity, which goes along the idea that the severity profiling should include evaluation of cardiac function in these patients. Now, we all know that since now 10 years ago, there's been recommendations to have screening for pulmonary hypertension for patients who have established BPD, both by AHA/ATS and PPH-NET. And that's the severity scheme that PPH-NET has recommended, which is largely based on the status of the right ventricle as well as the degree of reads on pulmonary pressures. So, for example, the most severe patients have more than 2/3 systemic and have severe RVH or RV dysfunction. We've also looked at our population in a screening era, and out of 222 patients, and you can think that these patients may encompass some patients with milder disease that are detected by screening. We found that we had still 8% of mortality, and that in these patients, there were signs using spectral tracking echo that had both RV and LV alterations at the time of PH diagnosis. So even in a screening era, cardiac function may already be affected starting at 36, 37 weeks. Whether or not this will resolve or lead to adverse outcomes require more research that we're currently undergoing. So on the long term, why it's so important that we look at this when we're in the NICU base? Well, first of all, because we can have a lot of impact when we start helping these babies at the fetal neonatal stage, because then they go on their life and exposed to many insults, but also because we think that they may drag some of these things as they grow into adulthood. Recently, one of our fellows looked at our population of patients at 4 months of age and looked at the extreme preemie babies, like the 22 to 24 weeks compared to the more than 25 weeks. And what she found is that there was still a significant portion of them that had signs of PH at 4 months. And they also had some degree of altered RV function, although the metrics were within normal. So whether or not these were resolved with time requires more intensive follow-up. This is not surprising, knowing that when we look at adults born preterm in the happy cohort, we found also that babies or adults that were less than 30 weeks had actually lower RV function by TAPSE and tissue Doppler compared to term counterpart. And this was even more so pronounced if they had a history of BPD. This has also been described by the group of Caragos, where she brought patients with prematurity at adulthood to the cath lab and found that half of her cohort actually had already criteria for pulmonary hypertension by cath. So these patients have signs of RV disease. The group of the UK have also assessed them by MRI and found definitely that, preemies had decreased stroke volume, smaller RVs, and impaired diastolic dimensions, which points out that this is a lifelong condition that, if picked up in the neonatal space, potentially could be modulated. What about the left side? We talked a lot about the right side. It would be foolish to think that suddenly the left side is preserved of all these processes that affect the body. Well, the left side is affected by coronary disease, LV inflammation. There's postnatal growth that is affected. Steroids will impact the left side. And these babies have kidney injury. They have kidney immaturity, vascular stiffness. They have adverse systemic vascular profile. And this definitely can affect the left ventricle as these patients actually grow. So we looked at our cohort of preterms less than 29 weeks, and we found that actually the tinier babies, when they were at 36 weeks corrected, had the smaller left ventricular size compared to those who were born more mature. And that's despite the fact that this was normalized to their height, to their weight, to their length. This seemed to be very inherent to the left ventricle, which may seem to show that there's a degree of arrestive development of the left ventricle in the tiniest preterm. Sylvia Nogara, who came to our lab, actually looked at a population of 151 patients who were scanned at 36 weeks using 3D echo. And these patients were extreme preterm at 26 weeks. She applied this technology where we had captured 4D clips. And what she found is that there was again a gradient by both birth weight and gestational age of the size of the left ventricle based on the maturity level at birth or based on the birth rate. And there was also a sex difference, which may imply that there might be specifics to both sex that we'll need to think about in the future when we start looking at risk profiling for these babies. The LV in the neonatal space is one thing. We've known also that in the adult space, there's been reports that the LV of preterm infants is quite different, both from the MRI literature, but also from our happy cohort, where we found that babies were born preterm when they were adult, had smaller stroke volumes and cardiac performance by TDI compared to their term counterparts. So there's definitely seemed to be something that persists in time. And now we have the gap to fill to try to understand if there's things that we can do in the fetal or neonatal space in order to prevent adverse LV trajectory. So I've put here what's our PH protocol. You have the screening scan. We had people from nurse practitioners, cardiology, respirology, pharmacy that actually were involved in the development of this screening protocol. I'm sure many of your units have developed a screening protocol as such. I've put here in a big graph what we do, but we'll decompose this. First of all, the criteria is that we chose to scan all our babies less than 30 weeks if they were still requiring oxygen or respiratory support at 36 weeks. And we consider it in room air if these babies are profoundly small for gestational age as the sole risk factor. We try to do our scan at 36 weeks, but we will do earlier scans if they have specific risk factors, like being born extremely preterm at 22 to 24 weeks, being SGA, or being still on invasive ventilation or deemed symptomatic at 32 weeks. So the timeline is here that I just mentioned. The criteria that we do use mean pulmonary arterial pressure equal or more to 20 based on pulmonary insufficiency jet, or if we get a read by TR jet or restrictive duct or VSD or right to left shunt of an estimate of more than 40 millimeters of mercury by echo of systolic pulmonary arterial pressure. Otherwise, we use the motion of the interventricular septum and we try to quantify the eccentricity index. So these are representation of what we measure. We know that the pulmonary artery has a pulsatile blood pressure. TR provides you information about the systolic component. Otherwise, we look at a ductal profile if we have one, or we look at the interventricular septal motion. And if we have a pulmonary insufficiency jet, we obtain the peak and end diastolic velocities in order to estimate mean pulmonary arterial pressure. We know that pH comes in different forms and shapes and severity, and that the RV and LV can be affected in different fashion. We've put in our pH severity scheme these factors. We've adapted this from the Pediatric Pulmonary Hypertension Network. Here you'll find what would be concerning for us as signs of pulmonary hypertension as outlined before, but then we look at mild, moderate, or severe, which will dictate how we follow these patients, as well as the type of therapies that we will install, and our consideration for cardiac catheterization. So the mild, moderate to severe, again, uses the same criteria as the PPH-NET, but we've actually outlined what are the cutoffs by different RV metrics, and on echo that clearly provides us with a sense of what's severe, moderate, or mild. And this algorithm has been adopted by all the units in our province of Quebec through the TnECHO Quebec Collaborative. So this is an example of mild where there's a bit of an elevated TR, giving about a 40 to 45 millimeters of mercury of systolic pulmonary arterial pressure, but really nicely preserved RV function, vigorous RV, nice LV, and a very round septum in systole. This is a moderate pH where you can see that you have maybe a bit of RV dilation, slightly flattening of the septum, and reads in the 70s, which was closer to the two-thirds systemic in this case. We obviously always look at all our pulmonary veins and Doppler them at each ostium. If you don't Doppler, it doesn't exist. So please look at all the color flow as well as Doppler at all the ostium to make sure that they have a biphasic, triphasic pattern and no increased velocities. Finally, this is a severe profile of pulmonary hypertension that was associated with high PVR in this case. You can see a very angry RV pancaking the LV, dilated here, decreased RV function, and a TR of 93, which was suprasystemic in this case. We do have some patients that we see at 36 weeks that have high reads of TR, here 75, but that have these like large, unrestricted left to right shunts. This is quite rare that we see that, but when we see that, we're quite cognizant that this could be flow mediated or pressure transmission mediated, and we wait to see what's happening with the duct before acting upon these patients and avoidance of pulmonary vasodilation. Finally, very rarely we do see pulmonary vein stenosis, and we're very well aware that some of these babies may have a component of precapillary injury too, but this is out of the scope of this current talk. So follow-up, we actually follow up usually at 36 weeks. It's been if the echo has been done at 32, and if there's no pH at 36, we repeat one at 40 weeks if we're still on oxygen or rest support. And if this patient has not been screened at 36 weeks, either because came in our system later or a new onset of oxygen respiratory support, we screen as soon as possible. Based on the initial assessment, we'll have our scheme of follow-up, usually 1 month of mild pH, 2 weeks of moderate, and severe requires the multidisciplinary meeting with all the teams for the management and a much more aggressive follow-up scheme and treatment. And the outpatient setting, these patients are followed at our HOMO2 BPD clinic with respirology, neonatal follow-up, OT nutrition, and cardiology. So for the last year, we had 87 newborns admitted to our center. out of which 42 were oxygen or respiratory support at 36 weeks, so less than half, 7 of which had signs of PH, but none more severe, and 2 with still signs of PH at 40 weeks, so 5 had resolved signs of PH. Now, at 40 weeks, what's interesting is that we had 3 that were normal at 36 weeks that had mild signs of pulmonary hypertension and were referred to be followed in the community. So definitely this is a dynamic process, and I think our prelim data outlines this. Quickly on the BPD management with pulmonary hypertension, the guidelines of PPH-Net are great for that. We know that BPD prevention is key. If there's no lung disease, there's no PH. Typically, not completely true, but typically. And really, the medications are not always the initial focus. It's treat the lungs first, and then often this will get better. We do aim for nice saturations in these patients to avoid vascular vasospasm. We do airway evaluation and manage their reflux and aspiration by optimizing also their nutrition. We try to avoid overfeeding them or underfeeding them. Although the evidence is weak, our approach has been to initiate hydrospiro in these patients for 2 weeks if they have signs of pulmonary hypertension at 36 weeks. And 2 weeks later, if they're doing better, we stop it. We do parental teaching about PH crisis, CPR, and vaccination. We send many other investigations in these patients and involve many of our multidisciplinary friends, ENT/OT for an example. We do rule out pulmonary vein stenosis in these kids with moderate to severe PH. And then finally, for cath, if there's concern of pulmonary vein stenosis, a shunt, worsening or not improving, or suprasystemic PH at any point, as well as concern for LV functional alterations, we consider a cath with our cardiology team. INO and pH targeted therapy are really reserved if these different things have not functioned. Typically, INO is for severe acute pH crisis. And in terms of pulmonary vasodilation is when we have moderate to severe pH with signs of RV dysfunction, despite everything that we've done to improve the phenotype. So we use as first line locally sildenafil, but we're aware it may worsen reflux and VQ mismatch. And before we add other agents, we actually consider going to the cath lab. I've put this beautiful slide from Dr. Satyan. I've added the selexipag and riosequid here, but there's many other targeted therapy, and sadly, none of them have specifically been studied in an RCT for BPD-PH. Now, Massimo today is off treprostinil sildenafil and has a normal follow-up at 3 years. And I want to thank their family to be amazing allies and parent partners that helps me in my journey. And this is us at the Impact Parent Partner Conference. And this is Massimo today running, healthy and growing. And so this for us is a success story. So in conclusion, extreme preterm with BPD are at risk of PH, and I advocate, I like the guideline screening at 36 weeks. I think this can be done with TnECHO and a multidisciplinary support or cardiology. Multiple etiologies are unique to BPD because it's a heterogeneous disease. It is also a lifelong disease. And please remind your families and parents to keep that in mind when they're being followed by their adult doctor one day. So I've put all this content on the NeoCardioLab website, which is my platform for knowledge dissemination. If you're interested, the QR code is here. And I remain open for comments, questions, or insults. Have a good day. You can email me if you have any questions or clarification needs.